Welcome to Beyond Sound, the podcast exploring the ideas, innovations, and people shaping the future of hearing health. Brought to you by the Hearing Group, a leading global independent network of experts dedicated to advancing cochlear implants and hearing restoration through collaboration, education, and research. In each episode, we bring you insights from internationally recognized clinicians, researchers, and thought leaders who are transforming the way we care for people with hearing loss. Today's speaker is Kari Smilsky, audiologist and proud member of the Hearing Group. In this talk, Kari explores how remote care is reshaping cochlear implant services, from virtual candidacy assessments and remote programming to AI-supported speech perception testing and digital cognitive monitoring. As access to specialized hearing care remains a challenge for many patients, Kari shares practical innovations that are making cochlear implant care more accessible, more efficient, and increasingly patient-centered. Let's listen in.
Thanks very much. So I'm going to look at things from a little bit different lens. I think in a perfect world, our patients would flow into our clinics really easily. They would have easy access to their local healthcare provider. Our community partners would be aware of what cochlear implant candidacy criteria looks like. There would be a really clear way for patients to get referred to our programs, and it would be easy for our patients to attend appointments. But I think we're all aware that this is not the case, and most of us work in large academic centers a great distance from where most of our patients live. It's also really expensive for patients to get to us in some cases. In the province I work in, there's 15 million people, and while a third of the population does live in the south, where the cochlear implant programs are located, there's more than 1 million people that live in the north, upwards of 13 hours away from our centers. So I think if we look at remote care as a pathway to really have patients access all of the cochlear implant care that we can provide, it will make things much easier and accessible to a lot of these patients. We work on awareness and educating our community partners, but even still, almost 70% of the referrals that we see in our program are coming to us from ENTs. So that means that these patients need to seek out their general practitioner and get referred to a community ENT before they even walk through our doors. So one of the first steps in our acceptance of remote care really happened during the pandemic. And pre-pandemic, we were assessing patients, I think like many centers, where we would receive a referral. The patient would be seen by audiology, they'd be tested for vestibular, they'd have a CT scan, and then they would see the surgeon. But during the pandemic, this wasn't possible, so we switched over to an initial virtual screen. So our ENT now meets with patients who are referred to our program first, and most often this is done via Zoom, which might sound unusual if you think about assessing a hearing impaired patient, but Zoom actually allows for closed captioning, it allows the family member to attend, and we don't have to wear a mask. So it actually really is a way to provide patients with good information to make an informed decision before they even have to travel to our clinic. And if we look at the conversion rate of the number of patients who move forward with cochlear implantation, it's exactly the same if they meet with the surgeon remotely first. So that really made us think about how we could service our patients remotely outside of that initial counseling. And during the pandemic, I think like many centers, we were packaging laptops with programming cables and shipping them to patients' homes, which was great. It saved them a visit. And after the pandemic, many of the patients wanted to continue this remote access, but it was expensive, and it depended on the patient's technological skill to be able to connect their own speech processor. And it was hard on the equipment. So at the same time, we were developing a network of community audiologists who don't work with cochlear implants, but who are willing to offer their clinics for us to remote into. So patients actually attend visits at these local audiologists, and we remote in and do the cochlear implant programming. So that is an improvement, but still a bit of difficulty for our patients. And now we have things like HearCare, and remote programming, which has really made things easier for patients. So rather than them traveling anywhere, we can actually access them and program them from the comfort of their homes. And in our program since January, we have completed over 100 remote visits with patients, and the app-based programming is outpacing our remote hosted sites 2-to-1. So patients really want to be seen locally. So that made us think, well, if they meet with the ENT and then they have to drive to Toronto for us to assess them, maybe we can assess them remotely. So what we've done is with our local partners, we have provided them with speech and word tests that they've loaded on their local computers. Patients attend the local audiologist where they're fit with consignment hearing aids that are programmed and verified so we know they're addressing their needs. And the sentence and words are streamed through a wireless device directly to the hearing aids. And in this way, we've been able to identify an appropriate candidate who then should come down to the city. This is the data on the first 5. So you can see the first patient that we assessed remotely scored 84%. So this was a really positive outcome because what it meant is he saved the trip and he was ultimately fit with hearing aids locally and was quite satisfied. Most of the agreement between the streamed sentences and our in-person assessment are pretty close. And for a lot of these patients, what we've done is we've screened them remotely. They've come to the city for their in-person assessment on one day, surgery the next day, early activation a couple of days later, and they go home with their implant. You may have noticed subject 4, who was screened with 5%, and when we assessed him the day before surgery, he scored 84%, which was a little alarming. But fortunately, this was a bilateral sequential patient with Meniere's, and he reported that the day we did his in-person assessment, it was quite a significant positive fluctuation in his hearing, which was atypical, and he did move forward with implants. So we can do all of this pre-work and programming remotely, but the one piece we're missing when these remote patients go home is how do we know how they're doing? Dr. Vincent Lin in our program, his trilogic thesis was to develop the hearing impaired MOCA, which is a cognitive screening test. And the value of this is it can be a predictor of follow-up cochlear implant outcomes. So better MOCA scores actually predict better speech perception outcomes. But it's really a screening tool, and it's not a way for us to track cognition changes over time. So what he's been doing is using the MED-EL Ready app, which some of you may be familiar with. And the Ready app is really designed as a rehab app where audiologists can design courses to administer to their students. But it has a lot of really lovely tools built in, things like voice synthesis, image generation, speech recognition. And so we've been able to use the Ready app to actually program a cognitive test to push out to patients on their own devices. So the goal was really to move beyond just the screening hearing impaired MOCA and really develop a cognitive test that can track changes over time. So using the features in Ready, we were able to develop visuospatial tests, attention tests, naming, all of these different cognitive tests. So that really got us thinking, well, wait a minute, can we use the Ready app to evaluate how our patients are doing post-operatively with their cochlear implants? So what we're working on now is we're actually loading AZBio sentences into the Ready app. The patient will be able to press the green button, which will play the sentence, and then using the voice recognition, they'll press the red button and verbally respond to what they think the sentence was, and that data is then transmitted back to our clinic, and the results are analyzed by AI. So there's a few limitations that we're working through. So the AI analysis really lets us know if the sentence was correct or incorrect. It doesn't give us the particular word score. It also tends to be a little more lenient than what we would assess in the booth. So for example, if a final consonant is dropped, if the patient says boat instead of boats, the AI will score that word as correct, where in the clinic we would score that as incorrect. To run this test, the patient should be in a quiet environment, and currently the Ready app does not have an indication of the room noise. And this is something we're really concerned about is we know our patients are motivated by good performance, and currently we're not able to restrict the number of times they play the sentence before they respond, and we're worried about learning effects over time. But our goal, once we have all of the sentences programmed, is really to look at a study whereby we'll be comparing the ready speech perception post-op scores to what we obtain in the booth. So our typical clinical CI follow-up is this. We see a patient for an activation. They come back at 1 month, and our goal then is to make sure that Ready is installed on their local device and that they're using it for rehab, so they have some familiarity with it. Our patients come back at 3 months. We test them in the booth for all of our patients, but with the study, we'll also be testing them with Ready AZ Bio sentences. We have dropped our 6-month follow-up, I think like many other centers, in light of clinic efficiencies, but it's a really big gap that we sometimes feel uncomfortable with if we're not sure how our patients are doing. So at 6 months, we'll have our patients self-administer a Ready speech perception score, and this will enable us to identify red flags for patients that maybe should be recalled sooner, or it will help us feel confident that we're okay to let them go to their 1-year follow-up. At 1 year, again, we'll test them in person and via the Ready app, and hopefully have some good data to show that these patients can be serviced remotely, even for follow-up speech perception testing. So I guess in conclusion, my goal is at some point to never have to go in the office again, and we'll be able to access our patients and service them remotely. So thank you for your attention.
Thank you for listening to Beyond Sound. We hope you enjoyed today's conversation with Kari Smilsky and gained new perspectives on how digital innovation and remote care are expanding access to cochlear implant services around the world. Beyond Sound is proudly brought to you by the Hearing Group, a leading global independent network of experts committed to advancing hearing restoration through education, research, and international collaboration. Kari Smilsky is also one of the many distinguished members contributing to this global community. Well, if you enjoyed this episode, subscribe to Beyond Sound on Spotify and YouTube so you never miss future conversations with experts at the forefront of hearing healthcare. You can also stay connected with the Hearing Group by following us on LinkedIn, Instagram, YouTube, and Facebook at Hearing Group for the latest research, educational resources, expert insights, and upcoming events. Until next time, keep listening, keep learning, and keep looking beyond sound.